All right. Now we can get started. So we left off at hypertensive emergencies. Oh, should I give the introduction since we're recording? Hello, ladies and gentlemen, boys and girls. My name is Brian. Welcome to the College of the Siskiyous EMT class. I believe class 16, but I'm not sure. We are now in the second half. All right. We're going to start with hypertensive emergencies.
Blood pressure is the force the circulating blood exerts on the walls of blood vessels. It is different in different types of vessels, but the term blood pressure, when not specified otherwise, refers to arterial pressure in the systemic circulation. When the heart contracts and pumps blood into the aorta during systole, the aortic pressure rises, and so does the systemic arterial pressure. The maximum pressure following an ejection is called the systolic pressure. In between heartbeats, when the ventricles refill, blood pressure falls to its lowest value called the diastolic pressure. These are the two numbers on a blood pressure reading. Blood pressure normally shows a daily pattern and is usually lower at night. During daytime, it fluctuates with physical activities and emotional states. Hypertension refers to a persistent high blood pressure. In the US, high blood pressure used to be defined as greater than 140/90, but recent guidelines have changed these values to 130/80 to better prevent and treat the condition. Normal blood pressure is below.
That's not true. That was financed by the pharmaceutical industry. It was to sell more blood pressure medication. Ooh. The physiology of blood pressure did not change.
120/80. In practice, blood pressure is considered too low only if it produces symptoms. Hypertension does not cause symptoms on its own, but it slowly damages blood vessels, and in the long term is a major risk factor for a variety of cardiovascular diseases such as stroke, aneurysm, and heart attack, as well as end organ damage such as renal failure or vision loss. For this reason, hypertension is known as the silent killer. Hypertension can be classified as primary or secondary, with the former being responsible for over 90% of cases. Primary hypertension has no apparent cause and may develop as a result of old age, obesity, high salt diet, lack of exercise, smoking, and drinking. Most commonly, the blood vessels are hardened with age or unhealthy diets, making it harder for blood to flow. Secondary hypertension, on the other hand, is caused by an underlying condition. Many conditions and factors can cause hypertension. Most notable are kidney problems and endocrine disturbances. Regardless of the cause, the increase in blood pressure is produced by either an increase in vascular resistance, narrower or stiffer blood vessels, or an increase in cardiac output, larger volume of blood pumped out by the heart. These two factors are the targets of antihypertensive drugs. Treatments must start with lifestyle changes such as healthy, low-sodium diets, physical exercise, and stress management. On top of that, antihypertensive agents may be used to control hypertension. These include vasodilators. These drugs dilate blood vessels, thereby decreasing vascular resistance and reducing blood pressure. Diuretics. Diuretics promote sodium and water removal by the kidneys and thereby decrease blood volume. Drugs that decrease cardiac output by decreasing heart rate or contractility may also be used to treat hypertension.
Does anyone have any questions on hypertensive crises and the dangers thereof?
What was the secondary? Other than diabetes?
Oh, diabetes, Cushing's triad, stroke. Trying to think what else. Wrong button. So, what is the terrifying biggest result that EMS will see from uncontrolled hypertension? Aortic aneurysms. Anyone's probably ever dealt with a garden hose or a fire hose, seen an aneurysm before. It's a weakening of the wall of the vessel from prolonged high blood pressure generally. So an aneurysm is the weakening of the wall. A dissection is when the aneurysm ruptures, the blood starts pouring out. Need to know the difference for tests. There's some very good animations of it right there on the screen. In the lower left-hand corner is an actual abdominal aortic aneurysm. It's huge. And it's not a bowling ball in their abdomen, it's a balloon in their aorta. Yes. Dissection. Kind of like what you did with lizards and stuff in broad grade school. That's what we call it in America. If you're in Thailand, we call it the tie dissection.
Reach on that one.
Yeah, well, I live in Mount Shasta. I see a lot of tie dissections.
So that section's the one that actually breaks.
Yeah.
Yeah.
I prefer the term rupture. What's that?
Patient does not have long to live.
No, it's pretty much over.
What do beta blockers do?
Beta blocker, that's an excellent question. How in depth of an answer do you want? All right. So your your sympathetic and parasympathetic nervous systems, the way they run is by certain types of chemical releases from the endocrine system of your body. Okay, so they've classified them into certain types of hormone releases or catecholamine releases from your endocrine system that are like keyholes that turn things on in your nervous system. So for instance, an alpha-1 is vasoconstriction and bronchoconstriction. Beta-1 is increased heart rate, increased heart force, and vasoconstriction with slight bronchoconstriction. Beta-2 is bronchodilation. So what a beta blocker is, the beta blocker goes in and it blocks the beta-1 and beta-2 from your nervous system being able to use it. So then when your body's endocrine system releases beta-1 and beta-2, it blocks that from happening. So your body can't increase the force of the heart and it can't vasoconstrict. So that's why they use beta blockers to combat hypertension. Because then your body can't vasoconstrict, it can't increase the force. Now, what happens is that also is blocking your fight or flight. So if you're walking through the jungle on a beta blocker and a saber-toothed tiger jumps out, you're not going to be able to run or fight for your life.
That's a weird feeling.
Not very well. You'll be like,
Keep going around.
in fact, I have seen doctors prescribe beta blockers to paramedic students before major tests because they freak themselves out, give themselves anxiety, and it blocks anxiety because anxiety is part of fight or flight. Yes.
That's like what Xanax is.
No, Xanax is a benzodiazepine.
That's la drug.
It's a benzodiazepine. It's a sedative, major sedative. Oh wait, which one did you say?
Xanax.
Xanax is a SSRI, isn't it?
No, it's a bit.
But
It's a benzo.
It's taken for anxiety and stuff like that.
Right, but it's a completely different process, pathology to relieve the anxiety. It's basically sedating, it's a sedative. Whereas the beta blockers block the actual chemicals that naturally stimulate your fight or flight. Any questions? 'Cause you remember we were talking about stress in the first week of class? It's the fight or flight, it's the constant fight or flight stress system being going. This blocks that from happening. Does that answer your question what a beta blocker is? Was it too in depth? Okay.
Are we taking beta blockers for the final?
No,
Okay.
in my opinion, that's cheating. Because if you get like a serious call, you can't go, hold on a second, don't staff the engine, I gotta get a beta blocker. No, it's not gonna work. They should not be prescribing beta blockers before they take tests. Exactly. What beta blockers is an addition? No. Funny, funny, funny. Yeah, it is. Everything's over the counter in Mexico. So my aortic aneurysm animation's gone. Jerks. Aortic aneurysm animation. It's almost like I've searched it before. Look at that.
Our ads work as hard as you do. I bring customers and sales closer than you can imagine. Small businesses saw 26% of their sales on average driven by Amazon ads.
The aorta is the largest artery in your body. Your heart pumps fresh, oxygen-rich blood through your aorta to deliver oxygen and nutrients to all your organs and tissues. Your aorta is divided into two main sections, the thoracic aorta and the abdominal aorta. The thoracic aorta has four parts: the aortic root, ascending aorta, aortic arch, and descending aorta. The wall of your aorta is composed of three layers that give it strength: the intima, or inner layer, the media, or middle layer, and the adventitia, or outer layer. The elastic muscular media prevents your blood pressure from rupturing the wall. Over time, degenerative disease may cause the media layer to break down, weakening the wall of your aorta. Blood pumping against the weakened area may cause it to bulge outward like a balloon. When this condition occurs in your chest, it is called a thoracic aortic aneurysm. These aneurysms may occur in one of several places, including the aortic root, the ascending aorta, or the descending aorta. Most thoracic aneurysms have no symptoms. However, when they reach larger sizes, various symptoms may appear, depending on the severity and location of the aneurysm. Symptoms of stable thoracic aneurysms may include shortness of breath, chest, back, or abdominal pain, difficulty swallowing, and hoarseness. If the aneurysm ruptures or dissects, more dramatic symptoms will appear, including a ripping sensation in the chest, severe pain in the back between the shoulder blades, dizziness, and difficulty walking and speaking. If you have these symptoms, you should seek immediate medical attention, as this condition is life-threatening. Blood pumping against weakened aortic walls can lead to another life-threatening condition called aortic dissection, which may or may not occur within an aneurysm. Most commonly, aortic dissection begins with damage to the intima layer. Blood moves through the break in the intima, separating it from the media, causing bleeding inside the wall of your aorta. As a result, a flap called a septum forms between the true aortic channel and the false channel. From here, the blood may break through the outer layer of the aortic wall, causing an immediate life-threatening condition, or it may re-enter the aorta through another tear in the intima. Over time, a blood clot may form in the false channel. An aortic dissection may be classified according to its location and duration of symptoms. In the Stanford system, if you have an aortic dissection in your ascending aorta, it is called a type A dissection. All other dissections are called type B. The most common symptom of thoracic aortic dissection is sharp or stabbing chest pain, usually sudden and severe. If you have a type A dissection, you're most likely to feel pain in your chest. If you have a type B dissection, you're more likely to feel pain in your back than your chest. If you have these symptoms, you should seek immediate medical attention, as this condition can be life-threatening.
There's one simple hearing hack anyone can use to improve their hearing almost overnight. Did you know that hearing impairments have nothing?
What? So signs and symptoms. Chest pain, usually a sharp stabbing pain radiating through their back. They'll say like feels like someone's took a sword stabbing it straight through my chest, coming on my back. That's the classic presentation. You raising your hand?
I got a question, yeah.
Yeah.
Isn't AMI acute?
Myocardial infarction. Yeah, same signs and symptoms,
Okay.
but it's usually sharp. And in late stages, they'll have a demarcation line in their back with modeling below that line. There's no blood as it's dissecting. And no pedal pulses because there's no blood getting to their feet. But it's all leaking into their chest thoracic cavity. Not a good thing. Yeah,
How common is it with the dissection or whatever, where it actually clots and goes back into the false clots?
well, that's before a dissection when it goes into the false channel. Usually once it dissects completely to the outer layer, then you got big problems. You're gonna die very quickly. Unless you get into a surgeon that can graft it fast.
So what were they talking about when it clots? Okay.
They're talking about when it goes on the inner layer and it goes to that false channel. And sometimes it'll flood off and you can just live with this big old aneurysm. Yeah. Sometimes they'll just monitor it for a long time. What's that? No. First layer, an aneurysm, false channel. Yeah, that's what an aneurysm is. It's going to the false channel and it's putting pressure against the outer layer. So it's just making a big bubble. So what do you do? Very much, Diesel. Get them to somewhere that's got a surgeon that can fix this. So in the old days, when I first started, you go in there and pretty much any vascular surgeon had cadaver aorta pieces, I called them grafts. And what they do is they just go in and clamp either side of the aorta real quick, open the chest up, clamp either side, cut out the dissection, put the other one in, sew it together real fast, and let the clamps go and fix it. With a lot of complications, a lot of dangerous. Now, if you go to Stanford or UC Davis or UCSF, one of the universities, they can do this. They don't even split your chest
Talent
anymore.
thoracic deployment. This animation provides a brief overview of the delivery and deployment of the Talent thoracic stent graft with the Accelerant delivery system. Please reference appropriate product instructions for use for a
Just
more
go through
detailed
your
list of
groin.
indications, warnings, precautions,
Appearance
and
through your groin.
potential adverse
Pretty cool
events.
stuff.
The Talent thoracic stent graft system features the easy-to-use Accelerant delivery system. The Accelerant delivery system consists of a single-use disposable catheter with an integrated handle to provide the user with controlled deployment for accuracy. The Talent thoracic stent graft system is used to treat descending thoracic aortic aneurysms and is a minimally invasive alternative to open surgery. After preparing the Accelerant delivery system using the procedure found in the instructions for use, it is important to first locate the radiopaque markers on the Talent thoracic stent graft to identify the location of the connecting bar within the sheath. Turn the sheath to align the connecting bar with the outer bend of the target vessel for implantation. An unaligned connecting bar may increase the likelihood of endoleaks post-implantation. Advance the delivery system through an incision in the femoral artery over the guide wire to the target landing zone. Be sure to monitor the proper orientation of the connecting bar while advancing the stent graft. Ensure that the proximal and distal springs are each placed in adequate landing zones, at least 20 millimeters proximal and distal to the aneurysm comprised of healthy tissue.
Initially position the proximal edge of the covered portion of the stent graft a few millimeters higher than the targeted landing zone. Confirm using angiography that the orientation and placement of the proximal end of the stent graft is exactly where you want it to land prior to deployment. Verify that the connecting bar is oriented on the outside of the outer curve of the thoracic aorta.
You guys get
The
the
mid
point?
marker figure 8 indicate.
Yeah, absolutely. Yeah. Most rescue squads have one of those sitting in their box. Yeah. All right, let's see what you guys have learned. You've been dispatched to a possible heart attack in a residential area of a small town. It is mid-afternoon. What comes first? Yep, scene size up. Don't forget, you guys are gonna try this in a small town.
Oh, that was a good one. That was good. Almost hit me.
All right, TIs or BSI on, scene is safe, you have a patient having chest pain, you got a full rescue squad, and your partner with you, and it doesn't appear you need to use spinal mobilization. What's next? What? Primary assessment. It's a mid-50s male, left lateral recumbent on the couch. He's alert with chest pain, has a strong radial pulse, his airway is clear, he's breathing adequately. You don't put him on O2 by mask, you put him on 2 liters of nasal cannula, you titrate to 94%. He's pale, cool, and wet, or moist, not wet. Moist. Who, is he a priority patient? I think he is. What's next? History taking. Signs and symptoms: chest pain, onset. Awoke at 07:30, provoked him when he awoke. Crushing quality, radiating to his left arm and jaw, 9/10 severity. It's been constant for 8 hours. The Nile is a lot more than in Egypt, a river in Egypt. Allergies: allergic to Advil, medication, lisinopril, and metformin for high blood pressure and non-insulin dependent diabetes mellitus, type 2 diabetic. Events leading up to it, he woke up with chest pain. What's next? Yeah, this guy's gonna be a cardiac trouble. Blood pressure 160/94, pulse rate 108, respiration is 20, GCS is 15. Everything's negative outside of that history. What do we do? Aspirin, 324 milligrams aspirin. What else? What? Get him out of there. ALS intercept? Yeah. Do you sit on scene and wait for it? No. All right, case history. I honestly have no idea what this is, but let's take a look.
Lifeguards respond to a viper help.
So, not just any beach, that's Waikiki. I gotta give these guys credit. I show you guys a lot of videos of what not to do. This is exactly the way a 911 emergency should run. These guys are, I'm sure they're all retired by now. This is almost 20 years ago, but this is top notch.
Lifeguards bring the unconscious man to shore with the help of Good Samaritans. Just bring him up all the way out of the water, try. As one lifeguard stays with the victim, lifeguard Gillis rushes for his medical kit. Each passing second could be the difference between life and death. Additional lifeguards come to the aid of the victim. They quickly work to assess the man's condition. The man is not breathing. Lifeguard Gillis tries to clear his airway. It's an unresponsive patient who is not breathing or not breathing adequately. ambulance is on the way. But if lifeguards can't expel the water from its lungs, it may be too late. I'll send in there as soon as possible. Back in Waikiki, lifeguards worked furiously to revive the elderly drowning victim, who is still not breathing on his own. They use a BPM device to get desperately needed oxygen into his lungs.
Yeah, it's a bag valve test, and we use that on unconscious victims that we're usually do it up there way everything.
The man is still not responding, and his vital signs are fading fast.
Breathe for the patient, and it's basically one breath every 3 to 5 seconds. The patient has a pulse, so we're not doing compressions, but we're just basically breathing for them.
The victim has been unresponsive for more than 7 minutes. His chances of survival fade with every passing second.
Hey, buddy, can you hear us? Can you squeeze my hand?
Lieutenant James Sloan races to the scene and finds the dire situation unfolding. Honolulu's fire department corresponds with the lifeguards. The victim is still unresponsive when suddenly. The man is now ready, but his respiration is weak and shallow. The situation remains grim.
Let's put him back down on his backboard, guys. Back down on the backboard, back down on the backboard.
Placed onto a backboard for immediate transport to the waiting ambulance. Lifeguards try to communicate with the man. An hysterical relative threatens to derail the rescue effort.
He's gonna be okay, no. So relax. He's okay. Hey, look, he's okay, okay? He's breathing away. I'm not breathing.
The woman may hold vital information that could save the victim's life, but her broken English has lifeguards struggling to understand her.
Has he any medical conditions that we should know about?
Extreme heart trouble could cause him to go into cardiac arrest. Time is running out. Lifeguards must quickly transport the man off the beach to a waiting ambulance for advanced life-saving techniques.
His condition, as far as health wise, he probably have the best, but he's looking pretty good at this time. This patient been alone and in rougher water. My guess is that he would not have survived without patient. Plenty of that pad of bullets and one breathing, so that's good.
Good job. So he spit out the opiate, he puked, so that means that his gag reflex came back, so he got enough oxygen going to his brain. He's too hypoxic to even have a gag reflex before. That means you're actually making progress. Over the sirens and the. All right, so aspirin. Aspirin developed today, man. Pharmaceutical companies make a fortune. But fortunately, aspirin came out before the FDA could get the red tape rolling. So it's readily available over the counter. It's an antiplatelet, it's an analgesic. It's basically a cure-all. This will literally stop heart attacks in the tracks. Not stop them or prevent them. What it can do is it stops them from getting bigger and growing. Does that make sense?
Yeah.
So you don't give it to people you think have GI bleeds. They're vomiting blood. You probably don't want to give them an antiplatelet. Once had a trucker that had a GI bleed, so he took half a bottle of aspirin. Yeah, we couldn't stop the bleeding. All right, nitroglycerin. This mixed with sawdust, not just kidding. Comes in pills, sprays, cream, patch. It is a smooth muscle relaxer, which relaxes the arterial walls and causes vasodilation. So more oxygenated blood can go to the heart. Make sure you do not give it or assist someone with it after you get a vasohospital order if they have any other vasodilators on board, especially sexually enhancing drugs. It will cause a fatal drop in blood pressure. Put the two of them together. They potentiate each other. In other words, 1 + 1 = 5. That's what potentiation is.
Lower 100.
You don't give it to begin with. Blood pressure's got to be over 100. Take vitals before and after any medication. Don't give it to people with head injuries. Don't give it to people that you think are having a stroke to lower their blood pressure. The reason why their blood pressure is high in the stroke is because of intracranial pressure. If you lower the blood pressure, then no blood gets to the brain dies immediately. So that's why you don't do that. Any questions? Yes, sir.
Will it potentiate with itself, or is it just a difference? So if they had 3 doses of nitroglycerin already.
No, the half-life's only 5 minutes. It's done. So nitroglycerin, if you expose it to light, it loses its potency. A lot of times, huh?
So it comes in a little dark.
Brown, yeah, exactly why. And a lot of times people with their home nitro, it's expired or it's not working or it's been exposed to light. It hasn't been stored properly. It won't work. Very common. They should feel a fizzling sensation on their tongue, and they should get a headache and get relief of the chest pain if their nitroglycerin is working properly.
So when you're administering that, would you actually have, like, if you're administering their nitro, would you pass down?
I wouldn't administer nitro. For you, if I was you? No, I mean, you're gonna give it anyway. But if they don't feel, yes, you would ask if they have fizzling on the tongue or have a headache, yes. Sorry, I'm a little punchy. Once I figured out what your question was. Oh, look at that nice picture. Take vitals before and after. You don't think that's real? Don't most nursing homes have a blue screen backdrop. So if you're gonna assist with nitroglycerin, check your R's. Any questions? No questions about nitro, huh? Make sure they're sitting down. Make sure they can't fall out of the chair. There's always a chance of syncope with nitro. All right, that brings us to surgeries and pacemakers and coronary artery bypass grafts. When you expose someone, you see a little bump under their chest, usually a rectangle or a circle. It's probably going to be a pacemaker or a defibrillator pacemaker. If someone has a defibrillator internally implanted, you're doing CPR and it shocks, it will not hurt you. You might feel a little numbness and vibration. You'll feel a little shock, but it won't be bad. It's usually only 2 to 6 joules, whereas in the AED, it's fire with 200 joules. If you're in contact with a patient with an AED, it will hurt you.
But you don't need to find out, right?
But
The difference.
no,
Okay.
I can tell you it hurts. And I've had that hit me more than once. I have a very bad habit of straddling dead people's arms while they're getting shocked. Then their arms come up when they get shocked. It's happened more than once. I think you'd learn. That's what it would look like under a X-ray. What these things are, they put them in the chest, they run the wires of the heart, they connect sort of pacemakers. Batteries last a long time. They can also set them up as defibrillators too. Don't put the AED directly over the pump though. Put it above it or below it. So it monitors the rhythm and gives a shock if it needs to. Then the pacemaker, the heart rate gets too slow, the pacemaker will give an artificial SA node and a signal will depolarize the tissue itself. Cause it. Pacemaker, it's pretty cool stuff. All right, AEDs. Put them on, press the button. It'll tell you if the patient needs to be shocked or not. Review of electrocardiophysiology, any changes? No changes. Any questions? Yes, the AV node. V is in Victor. Just think, backup's abbreviated AV. In Latin, backup's abbreviated AV. So you can just say that because no one knows Latin, so they can't say you're wrong. That's a joke. Don't write that down. So we already went through all this. Any questions on automaticity? About the ability of cardiac cells to generate their own electrical current, their own little power cells. Any questions about the electrical rhythms that we went over? Remember the preventricular contractions? This is the one guy starting to yell across the bar for the big bar. He does it right on the T wave. See how close he is to the T wave there? He does it right on that T wave you're gonna have. That's when multiple PVCs, that's when you got more than one cell. Now you got a couple guys in the saloon yelling at each other. And then one of them hits the T wave, and you go to fib.
That's from here. Bad day at stock market.
Does. Or an earthquake. So you hook the pads up, put a blast of 200 joules through them, down and back, depolarizes the entire heart, resets it. Hopefully the SA node takes over and gets the leader. Any questions? Look at that. That's a great picture of what you're trying to accomplish. Questions?
Yeah. Can you survive it? Fibrillation.
Now that's CPR or shock, sudden cardiac, sudden instant death.
Okay.
It's the leading, the drug relation is the leading cause of sudden cardiac death. What they do is shock. That's usually what it is. We're not doing that anymore because they've changed it. So defibrillator contraindications, and I've actually seen this done. You not put the defibrillator on someone with a pulse just in case they're going to go to full arrest. Although they're going to die, so I put them on ahead of time. Don't do that. Big no-no. If someone is, you're stopping to analyze, you have to have the patient holding still. You cannot continue doing compressions. You cannot shake their leg. Has to be holding still to get the actual reading. No one should be in contact with the patient when you push shock. You say clear, look around, make sure no one's touching the patient. Then you shock the patient. Don't worry about that. So this one's a little different. It's older. It's back when CPR was 15-2. And it's on the other side of the world. So you actually do CPR backwards because it's on the opposite axis of the world. What? Yeah. They're Aussies.
I love this show.
What show?
Bondi?
Oh. I don't know. I just got this one episode from it because it's actually good. It's a good save. Any questions?
What do you call that when you're doing the defense pathway, is that?
That one, that's the cerebral. Oh, agonal breathing? One second. Oh, heard you whispering. Heard you whispering.
Collapse. Lifeless. The stage is locked. It's not breathing. Chances that it has severe brain Goodman's son-in-law tries to provide clues to what caused the collapse.
You're right, They were taking a rest on the grass, sitting on the grass, and just went unconscious.
Lifeguards ready the AED. It could be the difference between life and death. The key to saving people that are having heart attacks is early defibrillation. It runs an analysis that basically tells you whether the patient has a shock in the rhythm. Fatal to restart is hard. I have years of actual breathing. Wake up. Breath, it's just noise is coming out of the windpipes. The patient is not actually breathing on their own. The man's chances of survival decrease with every passing second. Time is running. Paramedics have joined the efforts to save the life of the man in cardiac arrest. The patient is still pulseless and breathless, receiving respiration is impact on and chest compressions. Still not very good skin color, but we can all care. The victim's anxious attempts to reach family. Medical distress. Information can help the rescue team in this perilous situation. Paramedics administer drugs that could reset the man's heart. The drugs have no effect. His body reacts, but his heart does not. It appears at this time that he is essentially dead. He's not breathing and his heart's not working on its own. The challenge here is to get it back. Precious seconds continue to pass as the man remains lifeless. Shocks. Have delivered several shots. perform CPR, and inject its medications to prevent cardiac arrest with no success. With suddenly smart restarts. The man is in need of advanced medical care. Still unconscious, but now has a strong pulse. Got you. Continue everything we can to get back. The endless effort of lifeguards and paramedics has resulted in a miraculous recovery.
That's it. Miraculous. But- Any questions? All right, so we're gonna move on to chapter we're supposed to start tonight on. Holy cow, Brian. Neurological emergencies. So. Best EMS personnel in the world cannot save any patient alone. Feel to work cohesively as a team and support your team members. That is your effective work. You're only going to be as strong as your weakest link. The more you strengthen each other, the better you're going to be as a team. Any questions? So what are we going to learn about tonight? We're going to learn about the anatomy of the neurological system, how it works. We're going to go over the different types of emergencies, the signs and symptoms so you can identify those emergencies, and then how to treat them. Any questions? The brain and the spinal cord, central nervous system. Any questions? You should be pretty darn familiar with that anatomy. No questions, huh? You don't have to know all that, but it's kind of cool to know that's where all the generally the different things, the commands and stuff go. So there's your three parts of the neurological system: the cerebrum, which is a big part of the brain, the gray matter; the cerebellum, a little tiny golf ball above the medulla oblongata; then the spinal cord. Questions? All right. There's the cerebrum in full living color. So when the brain dies, or pieces of the brain dies, depending on where it dies, that's how the stroke affects you. Remember, a stroke is the same thing as a heart attack. It's just dead brain tissue instead of dead heart tissue. Any questions? Yes.
If you had a stroke and it paralyzed like half of your body, which part of the brain would that be affecting?
Well, it depends on which side. So if it's a stroke on the left side of the brain, it's going to paralyze the right side of your body. If it's a stroke on the right brain, that's going to paralyze the left side of your body. It's across wires. And we're going to go over different strokes, different heads of the brain here. There's some telltale signs and symptoms that will help you as an EMT know which side, even though it doesn't make a difference in your treatment. It'll at least let you know which side it is. So your cerebrum is divided into right hemispheres and left hemispheres, and they cross wire. The right hemisphere controls the left side of the body. The left hemisphere controls the right side of the body. The center of the cerebrum controls your touch and movement. The back processes the sight, and the front is critical thinking and decision making, which well, most males doesn't develop until very late in life. True. Proven.
Wrong.
Very proven. Much of the speech is controlled from the left side of the brain. So if they go aphagic, which is a lack of speech, they can't talk, it's usually a left brain function. They'll lose function with the right arm. There's that cerebellum. What? A fleet jet? Aphasia. Aphasia means unable to speak. Receptive aphasia means you don't understand what's being spoken to you. And expressive aphasia means you can't speak. Yeah, I can doctor on it. Then dysphagia is you speak and you, but it sounds like this. But you think that you said, hey, somebody get the cat a bowl of milk. And you're completely non-cognizant that you're saying, yeah, I've heard it a few times. Huh?
Word salad.
Word salad. Gotcha. Gotcha.
So instead of saying, I can't raise my left arm, the cat rises.
Gotcha. Cool thing is people that have dysphagia, which is if they can't get into physical therapy or rehab, they usually have a career teaching peanuts. Of course, you have to have seen a peanuts cartoon to understand what I'm saying. Or there's people that don't even know Charlie Brown is the sponsor, which is horrifically disappointing. Charles Schultz does not live in Santa Rosa. Been dead forever. Yeah. So you want to hear a cool fun fact? My cousin's in-laws managed the roller skating rink that he owned where he drew his cartoons at. He had a roller skating rink and he had a big window. He sat there and that's where he did his art. And he watched the kids and that's how he got the inspiration for the cartoons. It's the interaction with kids in his roller skating rink. Santa is still there.
There's all spread down.
So cousins, different cousin, though, not the one that had the house that managed the ranch. Yeah, it's got a nice new house up. He thinks it's an advantage. He's got his girlfriend to move out because it burned down. Then he can move back up. Apparently, it wasn't a great relationship. All right, ready? Let's go back to the future. Cerebellum. It controls attention, language, emotion, fear, pleasure, sensory, motor function, many others. Lots of parasympathetic stuff. Listen. Joke about shoot up with cerebellum. Huh? So. Joke right there. Are we ready to move forward? The medulla oblongata. The football is dead. Yeah. alligators don't have to do that. Yeah. Actually, I haven't seen it. So you don't believe that.
What?
Dude, I know.
Every time we start talking about the brain, I think that.
And he's one of my favorite actors too. You gotta think of the name, Gilbert Redner's husband. Willy Wonka.
Gene Wilder.
Gene Wilder, yeah. Springtime for Hitler, Germany. I gotta go see that. I could probably stream it. Probably got that. He's a brilliant comedian. And him and Richard Pryor together were fantastic.
Oh, here's no evil, see no evil. Such a good movie.
Silver Streak, there's so many of them. Of the bird costumes. Hear no evil, see no evil. Some kind of hero. There's so many of them. All right. Any questions about the brain stem? So what type of neurological emergencies are we worried about? Headaches. Huh? Headaches, stroke, seizures, and altered mental status. Headaches and altered mental status are wide umbrellas. They cover a lot of different things. Let's do it. There's a whole bunch of different types of headaches. And headaches generally are not life-threatening. However, the main three are going to be, sometimes they are. The main three that you're going to see are migraines, tension, and sinus. So migraines are very poorly understood. They still don't know what they are and why they happen and how to treat them. There's a lot of different theories, there's a lot of different treatments. It doesn't seem to be the same treatment works for everybody. Migraines also have a close association with seizures. They see an aura before it starts. There's a couple of really big links to seizures. Yeah. Sinus, we're gonna go over that. So tension headache is the most common one. Migraines is the second most common. Any questions? A lot of different theories. Hormonal dehydration. So the next most common is tension. That's usually caused from the tightening of muscles in the back of the neck. Cause pain in the head is what it refers to. It's generally attributed from being way too uptight. Yeah.
So say you just have like a really tight back, you could get headaches from that?
Absolutely.
Yeah.
Or they relieve a lot of tension headaches, but by back massage relieves a lot of it. Huh? Okay. All right, cluster headaches. These are the ones I get. Caused by hay fever, causes different pressures inside your sinuses as the stock moves in and out of chambers. Very painful. Good news is they're generally relieved with antihistamines. Any questions? Now, once in a while, a severe headache can be a life-threatening situation. Hemorrhagic strokes, brain tumors, meningitis are all life-threatening things that present with a headache. So they're go, oh, it's just a sinus headache. It's just a tension headache. Relax, dude. We're gonna go over that. But first, we're gonna talk about strokes, which is death of brain tissue, but they're called CVA, cerebral vascular accidents. And a cerebral vascular accident, just like an acute myocardial infarction, is caused by blood no longer flowing to the brain cells. No oxygenated blood gets to the brain cells die. Brain cells are dead, the brain does not work anymore. And just like heart cells, once they're dead, they're dead. So time is brain tissue. This is as time sensitive of an emergency as they possibly get. And you as EMTs can make the difference whether someone spends the rest of their life in the rest of their life in a nursing home going like this, or returning back to their normal life. You as EMTs can make that difference. Yes. So we're gonna go over things. If you can get them, if you can recognize and assess it fast enough and get them inside of a certain time window, 3 hours, you can actually reperfuse the brain just like the heart. And they can get 100% recovery that day. Now, if you don't get that, intense physical therapy can make a difference. A lot of times, those sometimes people don't ever get back to what they were. All right, so there's 3 different types of strokes. One, and these we're going to get to the headaches that you asked about. The most common is ischemic. And what does ischemia mean? Oxygen, not dead tissue. Lack of oxygen. Then we have hemorrhagic, which is when you're bleeding into your brain. And there's actually only 2 types of stroke, ischemic and hemorrhagic. This transischemic attack is not a stroke. It's like angina of the brain. It does all the signs and symptoms of a stroke. But if you rest or get oxygen, symptoms go away. Questions? It's not a stroke because the brain tissue doesn't die. It's just a stroke mimic. There's 3 stroke mimics. Things that look exactly have all the signs and symptoms of strokes, but are not strokes. A TIA is one of them, transischemic attack. Yes.
How serious is that compared to actual stroke?
How serious is a transischemic attack as compared to a stroke?
Yeah.
It's not nearly as serious because it completely resolves. However, it is a sign of an impending serious stroke if something doesn't get done to stop whatever's causing the transischemic attack. It's one clot away from being a major stroke. Ischemic strokes are 4 out of every 5 strokes. So you break loose an embolus or a thrombolus, a clot, travels through the bloodstream, lodges in your brain. Generally, just like with heart attacks, arteriosclerosis is the main culprit. Arteriosclerosis is a buildup of plaque on the inside of your arteries. Questions? There's a great picture, great animation about stroke works. Clot breaks 3, plugs the cerebral artery, everything does to that artery, it's dead. And if it's a big clot that blocks a large artery, call that an LVO, large vessel occlusion. You'll hear that term. It's an LVO. because LVOs do major strokes. Any questions? LVOs are not what you want to see. So if it's a left-sided stroke, you generally get some type of aphasia. Either you won't be able to understand what's being said or you won't be able to speak. Symptoms of aphasia means you can talk, but you can't understand what anyone's saying to you. Expressive aphasia means you can't speak at all, but you can understand what's being said to you. That's the difference between receptive and expressive aphasia. Questions? All right, signs and symptoms of stroke. Dysarthria, not dysphagia, dysarthria. When you say "Bungo Becky," but you think that you're talking normally. You're oblivious that you're saying, "We'll go wrong." To you, it sounds like you're talking normally. Any questions?
Yeah,
Yes.
so the book says that's slurred speech. Could that be like they almost sound like they're drunk?
Yeah. Next question.
Is there another sign of a stroke when it would have to face the
Right.
stats?
Facial droop. We're about to go over that.
So dysarthria, you get frustrated.
Right, because you can't understand them.
Yeah.
Sorry. And then they yell at you. They go, "Why can't you understand me?" But what they're yelling is,
Kylie Brad parents.
yeah. All right, so here's more signs and symptoms of stroke. Loss of function of one side of the body. Lose consciousness, syncope, that's fainting. Facial droop on one side. Sudden weakness or numbness. Slurred speech. Lack of muscle coordination, headache, and altered level of consciousness. Those are all signs and symptoms of a possible stroke.
Will it ever be on both sides?
I've never heard of a bilateral stroke, no. A hemorrhagic stroke can do that, so still squish it, but doesn't usually cause, usually only get the facial droop on the opposite side of where it started, from the side where it started. Blows the pupil, we'll go over that here in a sec. Yeah, the projectile, drill blow pupil. But we're only going to have ischemic stroke right now, though. I don't want to jump too far ahead and confuse people.
Sorry.
Yeah, row 3 just keeps trying to jump ahead. They're eager. They're eager for knowledge. All right. So, yeah, you guys can recognize they're having an ischemic stroke, and you can find out when the onset of symptoms was. You can get an absolute confirmed onset of symptoms. And you can get them into a stroke receiving facility within 90 minutes of the onset of symptoms. They can potentially give TPA and completely reverse the stroke, which is freaking amazing. So how do you know if someone's having an ischemic stroke? There is a test we're going to learn right now. If all 3 of these parts of the test are positive, the 90% accurate chance they're having an ischemic stroke. The first thing you do is you have them hold their arms straight out, turn them like a mummy, turn their palms up. If they have an arm drift one way or the other, that's a positive finding. Not good. Then you have them show your teeth, grimace. And you look for facial symmetrical. If they have a facial droop, that's a positive sign. If their face is symmetrical, that's good, negative. Then you ask them to repeat a sentence that has a lot of syllables and like, the sky's always blue in Cincinnati. If they slur the speech, then it's a positive sign. If you speak clearly, it's negative. If you have 3 positive signs, it's about a 90% chance you're having an ischemic stroke. So if you get that, if you have that, you can get a timeline of exactly when it started, and you can get them into that facility. Same thing, just like a trauma lawyer, you gotta let them know ahead of time, because they gotta get the CT scanner cleared. They've got to do a CT first to make sure it's on a hemorrhagic stroke. Because TPA, the drug they're going to give them, is a clot busting drug. Same when they give for heart attacks, they can't get to the cath lab. And the problem with clot busting drugs is they're not prejudiced. They don't know where to go. They don't go, oh, I'm going to the brain today. They can dissolve every clot in your body. So if you have a GI bleed, you had recent surgery, you fell down the stairs when you had the stroke, something like that, and you give this clot busting drug, they're dead. They'll bleed out. It completely eliminates all platelets, dissolves the actual clots in the arteries.
So what do they do if you have, like you have a stroke like this, right? But you have something contradictory that they can't give you blood thinner. Are you just kind of screwed?
Screwed. Yeah, I had a buddy that I worked with in Roseburg. He lived in Reading, commuted to Roseburg, which was stupid. But anyway, he had a stroke while driving the weed, and he wrecked his car.
Oh.
And because he wrecked his car, we couldn't give him TPA because he'd been in a car accident. So.
When you're doing the motor test, for
Yeah.
that, you want to have them close their eyes too.
Preferably. But the big thing is, generally in my experience, when you ask them to raise their arms, it's going to be like this if it's positive. They can't even raise it. TBA and TNK. So TBA and TNK, there's really no difference outside of the way that they're given. They're competitive pharmaceutical agencies. One's like by Merck and the other one's like Pfizer. And the difference is TPA, you got to mix and it's a drip that takes like 30 minutes. TNK is a one-time push, but it takes 30 minutes for it to take effect. Comes out about the same. A lot of hospitals have moved to TNK because there's a lot less margin for error. You draw it up and you inject it in the IV line and you're done. You don't have to mix the TPA together. You don't have to do the drips. You don't have to get the right drip rate. There's way less margin for error in TNK. And for like cardiacs, where you're going to TNK them and then ship them, it's much faster because you get hit with TNK, send them right back out the door with the paramedics. Whereas the TPA, you got to wait 30 minutes for it to drip in. Then if it doesn't work, you're really screwed. That's a ischemic stroke. 1 or 2, it's not. It's probably not a severe ischemic stroke, or it might be something else, a stroke mimic. If it's all 3, it's probably a stroke. In this county, both Mount Shasta and Wairega are stroke receiving facilities. They got TNK and they've got robots, but the neurologist gets into the robot and comes into the room and talks to them with their face on the screen and everything. It's pretty cool.
It's 90% affected. Is that other 10% bigger? Or is that
90% of the time, it's an ischemic stroke. The other 10%, it's one of the 3 mimics.
oh,
It's a TIA, hypoglycemia, or a post-ictal phase. We're going to go over this. Any questions? So it is critically important that EMTs, if you have people with signs of stroke, that you immediately, when you get there, do a Cincinnati pre-hospital stroke screen and build a timeline. And if it's positive and you have an actual timeline, contact the closest stroke receiving center and give them an ETA of when you're going to be there. They will have the CT scanner cleared out and they'll be ready to go, and they'll probably have the ambulance go past ER straight into CT. Then there'll be somebody standing outside the CT with the TNK syringe to hit them with the TNK as soon as they come out of CT.
how would you consider that on firefighters? You get there first. We take that over the radio.
You get on the radio and then get them extricated so they're at the door. So it's the ambulance drives by, you can throw them out the door into the ambulance, the door open as they go by. which is exaggerated, but basically don't have them up in the back bedroom on the second floor and go, yeah, thought we'd wait until you got here. I think he's having a stroke. Don't do that. Put them in a chair, put them in a carry-on, drag their butts down to the front door and be waiting. Then when the ambulance gets there, pull up and say, Cincinnati Cross stroke screen is positive. At 18:32 is the onset of symptoms. You guys call a stroke alert and go. And they can just load straight into it. And if the paramedic starts going, oh, let's check this, just go. Call their supervisor. I'll stick their hand in a pot of boiling oil. Don't do that again. Yeah, no, seriously though, but time is everything. On a serious note, time is everything. The timeline is not as easy as it sounds. Somebody's got to call 911. A lot of times people don't call 911. They go, wow, Uncle George sure is acting when he dropped his spoon and he's not talking. Why is he drilling? I'm not kidding. It's sad but true. Yeah. You know what? Aunt Jeannie's cousin's brother-in-law's cousin was a paramedic 25 years ago. Let's call him and see what he thinks. Someone find his phone number. Let's make 6 phone calls to get that phone number for someone who has no idea. You know, Uncle Joe watches a lot of those medical shows on TV. Let's call him. All right. So the onset, so it's got to recognize someone's got to activate 911. You got to be able to get there. You got to be able to establish the timeline. You got to let the hospital know ahead of time. You got to get them to the hospital, give them the CAT scan, and they got to go through a 2-page list of rule outs where any one thing is positive on the 2-page list, they don't get the TPA. Then they stroke out, then go to rehab, and hopefully months to years later, they're able to trade other parts of the brain that aren't dead how to do the basic functions of life. Yes.
Can you have like different severities, like regardless of just the time zone? Because my aunt had a stroke and I believe she just pulled over and called and it wasn't really bad.
Right. No, you can have minor strokes, you can have massive strokes.
Yeah.
Depends on where the clot, depends on how big that clot is and how much of the distal of that clot gets killed. Does that make sense? As I said, the LVOs, the large vessel occlusions, are real hard to come back from. And also it's a lot less likely the TNK is going to dissolve this. So those that want to try to go into what's called an advanced stroke center, which is in Reading or Medford, and they have what's called interventional radiology, and they'll go in with a suction cup through the leg, and they'll try to suck the clot out. Yeah, try to pull it out.
It says onset of symptom has to be accurate. So by now, like bystander, who just happened about 20 minutes ago.
Yeah, you got to have it exact because this is a dangerous drug. Or if they woke up with it, yeah, she woke up this way. It's too late. Or I went to the store and I came home and my wife's like this, and I was gone to the store for 45 minutes. Like you can say, if you can honestly say 45 minutes, because it's the time when he left for the store. So you have to go back to. You can't say any time in between them. You know, it's got to be an absolute, they call it last seen normal time. When was the last time someone saw this person normal?
So if they went to bed normal, woke up with it, it'd be when
they're screwed. Yeah, it'd be when you went to bed. Yeah. And you got to be clear about it. It's like I once asked a guy, when was the last time your wife was seen normal? He put his hand on my shoulder and said, she's been on Ativan for 14 years. I'm not kidding. You got to be specific on what you're talking about. Any questions on the Cincinnati pre-hospital stroke screens? A 90-minute window. Yeah. We're saying now up to 3 hours, but 90 minutes has an excellent, excellent chance of recovery. 3 hours still has a chance, but not as good as a chance. Now they're going up to 6, but that's just so they can sell more TNK. For LVOs. All right, now here's something we hope you'll really like. Nobody in this room knows what that's from. You do? Oh. It's not.
I thought that was Brian, literal.
Oh, no. Yeah. No. It's an expressive basic video. That's so funny. But looks at everything.
Lowe's knows the best pros.
This one's got sound.
That's why Lowe's is bringing you the largest in-store selection.
A stroke occurs when the blood flow in part of your brain is blocked. After just a few minutes, the starved brain cells begin to die. Blood flow in part of your brain.
See that right there? This thing? That's called the circle of Willis. That might be on your chest. Willis? Circle of Willis. That's why you guys hear me say all the time, what you talking about, Willis? That's what I'm talking about.
Is blocked. After just a few minutes, the starved brain cells begin to die.
But not old enough for here's something we hope you'll really like.
Normally, the brain receives blood via two major pairs of arteries,
60s, not 50s.
which branch throughout brain tissue and supply your brain cells with a constant flow of oxygen, glucose, and nutrients necessary for their functions. In one type of stroke, ischemic stroke, an artery in your brain narrows or becomes completely blocked, preventing normal blood flow. The blockage may be caused by a blood clot, also called a thrombus, which forms in an unhealthy artery of the brain. The lack of blood flow causes the tissue the artery supplies to become starved or ischemic. Similarly, the blockage may be due to an embolus, a blood clot that forms elsewhere in the body and travels to the brain. The embolus lodges in a narrowed artery and obstructs blood flow. Immediate treatment for your stroke may help to minimize brain cell injury and death. If you have an ischemic stroke, you may be given medication to break up the clot causing your stroke. Later, your doctor may recommend surgery, such as carotid endarterectomy, to reduce your risk of having another ischemic stroke.
They don't do that anymore. That way when I came in.
This is a metabolism killer. This is a metabolism killer. And even
So oxygen, 2 liters red, titrate to 94%. All right, here's TPA.
Activase, also known as recombinant tissue plasminogen activator, or TPA, is the only drug approved by the FDA for treatment of stroke.
Not anymore.
Growing plaque can rupture, promoting thrombus formation by activating the coagulation cascade. Platelets and red blood cells aggregate at the site of injury, causing further narrowing of the artery. This impedes blood flow even more and causes turbulence in the artery. It also increases the likelihood of thrombus formation.
As the thrombus grows, it causes increased vessel narrowing, leading to partial or even complete occlusion. The occluded artery leads to ischemia and tissue necrosis. When a piece of thrombus breaks off, it's called an embolus as it travels up the artery. During a stroke, ischemia can progress to infarction. Beyond the infarction lies still viable tissue called the penumbra. Cells within the penumbra are potentially salvageable if blood flow and vital oxygen are restored promptly. The penumbra is the focus of fibrinolytic treatment. Now let's look at the thrombus itself. Inside the thrombus are strands of fibrin, the protein that forms a clot. Enmeshed within the fibrin is plasminogen, the inactive precursor of plasma. Activase is administered by IV infusion within 3 hours of acute ischemic stroke symptom onset. Activase binds to the fibrin in a thrombus and converts plasminogen to plasma. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, blood flow is restored, and viable tissue may be reperfused. Although the original infarction remains, when surrounding cells in the penumbra are saved or reperfused, function may be restored. Activase, the 1-TPA for stroke, is the only drug approved by the FDA for this indication.
There's another way they can do it. They can go in and actually pull it out.
Treatment of acute ischemic stroke with clot retrieval device.
This is what they do under interventional radiology.
Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.
All right, one more video before you guys go to break.
I have a question. Does anybody know what they used to create the very first blockbuster medication?
Trina?
Aspirin?
No, not aspirin, not Drano.
Mercury.
Yeah.
Automet.
Rattlesnake.
All right, here you go. Oh, so you do a Rocky boy.
Hey, Rocky, watch me pull a rabbit out of my hat.
Again?
Look for Steve. Crystal.
Wrong hat.
I take a 7.5.
Now here's something we hope you'll really like.
It was every Saturday morning. Now here's something we hope you'll really like.
Saturday morning.
And now what's up in this baby different?
End of the 60s, early 70s. Guys have never seen.
Playing well into the 80s.
Never, but you don't know it, but you never heard down here something we hope you really like.
It's just been a minute, man. Come on. I haven't seen Rocky movies and cartoons for like 3 decades.
What's amazing is YouTube won't even allow fractured fairy tales. What? Oh, that's why it's not YouTube. Yeah, that's what they would always put before fractured fairy tales. The people used to get so angry at fractured fairy
I
tales.
love fractured.
So do I.
September 29th.
So you guys go to break, be back at 8 o'clock, or you can watch fractured fairy tales. Fractured fairy tales.
Once upon a time, there was a girl named Cinderella who lived with her two sisters. Every night, the two sisters would dress up and go into town where they were popular and sought after scrub women. Night after night, Cinderella would stay home doing the chores.
It's work, all the time work.
Then, one day, she heard a strange little voice.
Cinderella! Cinderella! Who let that screen open again? Hey, why don't you hold it? I'm your fairy godmother. Oh, boy. All right, change me. Huh? Do me over, the gown, jewels, carriage, glass, everything like that.
Oh, you mean this model?
Yeah, that's it.
Of course, my dear, just sign here.
Sign what?
It's our little contract. I'll give you all these things.
I'll sign. There you are.
Fine, there you are. And in return, you will sell all this wonderful little cookware by midnight tonight. Just $39.95 a set.
I gotta sell all these pots again?
By midnight. If you want to keep all those goodies, even we fairy godmothers have to make a living, you know.
But there's only one man in the kingdom rich enough to buy this stuff.
That's right, honey. Prince Fascinato himself.
But Cinderella's fairy godmother didn't know much about royal finance, for the prince was, at that moment, saying to his prime minister,
This balance can't be right, Frobisher. My fortune runs to 6 figures.
Yes, your highness, but they're all zeros.
I am. But what about the royal sock?
The royal sock is empty, sire. And hark, the creditors are pounding on the castle door.
You mean?
Yes, you have until midnight to raise some money. Lots of money.
But my dear Frobisher, how?
Now else, you must marry a rich heiress.
By midnight?
There's a ball at the castle tonight. Do your best.
So, that night, the prince looked his guests over very carefully.
Uh-oh.
Something, your highness?
I think I got a live one, Frobisher.
And so the prince and Cinderella danced for hours.
You are the loveliest girl in my kingdom. Your eyes, your diamonds.
Those were sure terrible beans we had for dinner.
Beans?
Now with this skillet, you can cook the water this way.
Your teeth are like pearls. Your pearls like teeth.
Surprising closeness of Philistine.
Let us go where we can be alone, darling.
So the prince and Cinderella sought out a moonlit seat in the garden.
Oh, how long I've searched for a girl just like you. Since this afternoon, as a matter of fact.
And I know you're my kind of guy. Real spender.
Hurry, what about the creditor? I can't hold them off past midnight.
How's it going, dearie?
I'm just about to close the sale.
Tell them about our layaway plan. You've only got an hour left.
So the prince and Cinderella continued to speak of love and saucepans until almost midnight.
Such grace, such beauty, such real cash value. Will you be mine?
There's no vitamin waste, see? And they scour clean in a jiffy.
You've got just 2 minutes.
You have just 2 minutes.
Say yes, my love.
What's $39.95 to us?
I got work to do.
Yeah, I love her.
I know.
Yeah, so we're seeing it 100 times. Now, here's something we hope you'll really like. That's lawyers for 10 years.
Really?
I spent 10 years thinking about Brianism.
Did you think that what you talking about, Willis, is a Brianism too?
Right, I feel like you told me this, like.
Very much so. Influences from my life.
Yes.
Well, I shouldn't.
I would have loved to do that.
I have 280, 480s. I've had 680 kilograms since about before.
I don't know why.
It's 5. 5 in the afternoon. Exhausted.
This is.
I'm on day 8 of 24 hours. 26, so I got a long ways to go. Yeah, 280 and green tea capsules. Before I left, and I drank a 200 milligram on the way up here.
5, 5.
Yeah. You also like it.
Yeah, there's a guy.
Now you'll know.
It's actually why I used to.
Oh, yes.
It's just, yeah.
Eight months. Right, you joined the rear with Jen.
I feel like it's been so
Oh, you should the rear with Jen.
Yeah, so it's
It's like here's the problem. I don't know how this happens.
She's dead.
Yes, she is. So one move is longer than the
The
other,
other.
and then I
Oh,
end
wow.
up stepping on it. So
Do we have this on the OneDrive?
it will be. But it's on the one, right? It will be in the instructor folder. on the
This is
OneDrive.
also good for aspiring students to write out themselves. This is what I recommend they do. I recommend they take one of these a day and write the whole thing out as many times as they can.
I had a whiteboard.
I had plywood in here. Well,
Yeah, that's
great.
because you were born.
No, actually, well,
This is automatic.
I was a tender, so I would.
A lot of these students present. See, mine was.
So when do you come back?
Thursday.
Thursday.
After like 100.
You're back with the Brit. Have you told her yet? No.
Go through everything, but taking care of it. I just asked on him if I could go back.
Gotcha.
Just about the. Yeah. They leave.
Guess we should